morning, everyone. My name is Kim, and I'm a general surgery resident at the Cleveland Clinic. Thank you to Sages for this opportunity to share about our research on the association of permanent versus absorbable fixation on developing chronic post-herniorrhaphy groin pain in patients undergoing laparoscopic inguinal hernia repair. All right, these are our authors' disclosures. So briefly, chronic post-op groin pain is a relatively common complication that we see after inguinal hernia repair. The rates quoted in the literature vary widely, anywhere from 11 to 53%. This variation is likely due to the lack of a universal definition or a standardized assessment tool. Furthermore, the etiology of this disease is not well understood and thought to be likely multifactorial in nature. In addition to a number of patient characteristics and operative characteristics, mesh and its method of fixation are also thought to contribute. Traditionally, permanent titanium tackers were used as the standard for fixation. After a number of reported complications, concerns arose as to its association with chronic post-op groin pain, and this led to the development of alternatives such as absorbable tacks. However, a review of the literature shows that the literature doesn't really have much to support this conclusion. If you look at a study by Haney and Gamal, this was an RCT of 30 patients where they did not find any difference in rates of chronic post-op groin pain between absorbable versus permanent fixation. This was followed by a case control study of 20 patients by Prakash colleagues with similar findings. If you look at cost data, you find that at our institution, a absorbable tacker is $200 more per unit when compared to a permanent tacker. With almost 1,000 MIS inguinal hernia repairs per year, this comes out to a cost of almost $200,000 difference. Therefore, we aim to compare the rates of chronic post-op groin pain after lap inguinal hernia repair between permanent versus absorbable fixation. We conducted a post-hoc analysis of a prior RCT investigating the effect of intraoperative catheters on post-op urinary retention. This was a multi-center trial that was conducted between March of 2019 and March of 2021. In the RCT, the method of fixation was left up to the discretion of the operating surgeon. All patients received either permanent fixation with ProTac titanium tacks or absorbable fixation with Absorbitac synthetic polyester copolymer tacks. For this study, all patients in the original RCT were contacted at maximum follow-up to obtain URA-HS, quality of life, and hernia recurrence inventory assessments. As you see on the bottom left of your screen, the URA-HS is a hernia-specific quality of life instrument that's been validated for inguinal repair outcomes. The URA-HS scores symptoms from 0 to 10, with 10 indicating a worse effect and therefore interpreted as a worse quality of life. The two domains, pain and restriction of activity, were used in this assessment. The maximum score for pain is 30, and the maximum score for restriction of activity is 40. For our primary outcome, the rate of chronic post-op groin pain was defined as a URA-HS pain domain score of 4 or greater. There has not been a validated score for this instrument that's indicative of persistent pain. Therefore, we picked this cutoff based upon previously employed definitions that have been used in the chronic pain literature. Additional outcomes from the URA-HS included the average pain and the average restriction of activity domain scores. The hernia recurrence inventory is a patient-reported outcomes assessment that asks 3 questions. The question, do you feel or see a bulge, has been previously demonstrated to be highly sensitive and specific for the diagnosis of hernia recurrence. Therefore, it was used in our assessment, in our study, to identify the rates of patient-reported recurrence. Of the 491 patients who were randomized in the original RCT, follow-up was successfully obtained for 345 patients. Operative details were not available for 7 of those patients, and so therefore we included 338 patients in our analysis. Average follow-up for the full cohort was 26 months, and maximum follow-up was obtained at 2 years for most of our patients. There were no statistically significant differences in patient baseline characteristics. However, for operative details, patients receiving permanent fixation were more likely to have had prior inguinal mesh, larger hernia, undergo a TAP repair, receive more tacks, and had a longer operation. For our secondary outcomes, there were no differences in the average pain or average restriction of activity domain scores, nor was there a difference in the rate of patients reporting an inguinal bulge. Our overall rate of chronic post-op groin pain at maximum follow-up was 16.3%, 18% for absorbable fixation, and 15% for permanent fixation. This difference was not statistically significant. On multivariable analysis, age, BMI, hernia size, and number of tacks used were not associated with chronic post-op groin pain. For patients with absorbable fixation, there was a 1.3 times odds of developing chronic post-op groin pain when compared to patients with permanent fixation. This, again, was not statistically significant. So in conclusion, mesh fixation with permanent tacks does not appear to increase the risk of developing chronic post-op groin pain after lap inguinal hernia repair when compared to fixation with absorbable tacks. Thank you. Happy to take any questions.